Hello and welcome to the session for April of 2023 on low-grade spindle cell lesions, a challenging area of differential diagnosis. So I've put together about 6 or 7 different topics for us to look at some case examples. And then if you have questions, we can discuss them as we go along. So I think when you approach any sort of soft tissue lesion, there are several things that you need to bear in mind. The location can be quite different for different tumors. And so recognizing that what you see in the lung will be different from what you see in the abdomen, perhaps from what you see in the peripheral extremity and so forth. Age also is an important consideration. And then there are a number of syndromes that have these low-grade lesions as well. And I would look at these things first before I start worrying about what to do with immunohistochemistry and molecular tests. Because if you don't have these things in mind before you start doing this, you'll waste a lot of money looking for the wrong answer. So let's start with a very common lesion, the fibromatosis or desmoid tumor. And as you know, there are some variations on this theme that have the same name or a similar name, but may be somewhat distinct molecularly. These can be both superficial and deep. Although the majority of the serious ones are more deep, but sometimes on a superficial trunk site, the superficial ones can be more concerning. The more peripheral ones, the palmar, plantar fibromatoses, are usually less serious versus the central one. But both of these can have mutations in the beta-catenin gene as well as in APC in some situations. And they can occur in a wide variety of settings. So I've got several cases to kind of illustrate the morphology. So here's a nice example. You'll see sort of a lobular pattern at low magnification. And these really are quite bland looking lesions. So the cells are not large. The nuclei generally have kind of a pointy, slightly stellate or spindle cell proliferate pattern. And the background is often kind of this wavy collagen like this with maybe some myxoid change, maybe some red cells, sometimes a little bit more fibrosis. It's very unusual to find mitotic figures or any degree of necrosis. But as you can see, you'll have a bit of a vascular background, small vessels coursing through this. And usually with the deep ones or the more serious ones, the margin is fairly well circumscribed, although as you see, it can have sort of an infiltrative capability in these nodular growth to extend into deeper structures. Now, this is an important diagnosis to be able to make on needle biopsy because increasingly this is not a surgical disease. So this can increasingly be treated with various medications or targeted therapies that can make it easier to manage. Here's another example, again, right abutting deep skeletal muscle, and you see a very similar pattern. Rounded, circumscribed margins, low vascularity, very bland looking spindle to ovoid cells, stellate cells, and a collagenous matrix. So how do we make this diagnosis on a needle biopsy? Well, the morphology is and sort of history is very important. And then I think the next very important thing is to be able to do a good quality beta-catenin stain. So this is a beta-catenin stain on a needle biopsy. And as you can see, we get some nice nuclear positivity as well as cytoplasmic positivity. So you don't want to just see cytoplasmic, you want to see nuclear positivity in many, if not all of the cells. Here, some of them are negative, most are positive, and then some cytoplasmic positivity. But the challenge with this immunoperoxidase stain is that it's not 100% sensitive to the mutation. And so there are cases where if we have a negative beta-catenin stain, we will send the tissue for genetic analysis to look for CTNNB1 mutations because they don't want to do surgery on this if they don't have to. So that's kind of the trick with this is that it can be a helpful diagnosis if it's positive, but if it's negative or it isn't available to you, it's a little bit more challenging. Here's another example. This is, I think, intra-abdominally, and here you can see an adjacent lymph node. And this case is, again, low cellularity, fairly collagenous, but very bland cells, and this sort of wavy collagen fiber backdrop. No mitotic activity, no atypia. There can be some admixed mast cells in these lesions as well. That's not particularly diagnostic or worrisome either way. Now, in contrast, this is what it would be called the peripheral fibromatosis. I believe this was from the plantar fascia. And here you can see that, again, there's not a lot of atypia to this process, but there's variable cellularity in these lesions. Some areas more cellular, some areas less, and varying degrees of dense fibrosis associated with these. So there are a number of medical treatments for this as well, but usually this would, if it's not disfiguring or impairing function, may not be removed at all. But it's essentially the same histologic appearance, just in this different location. Okay, well, let's contrast this with solitary fibrous tumor. This is something that you will see fairly frequently because it shows up in a wide range of locations, usually in adults. Most of the time, this is a deep tumor, and the superficial tumors may be hard to distinguish from some other problems, other tumors like Dermatofibrosarcoma and so forth. But this is very helpful now that we have a very specific immunohistochemistry for STAT6, which reflects the presence of this NAB2 STAT6 fusion gene, which is very specific for solitary fibrous tumor and has helped us to sort of unify this diagnosis. I still remember as a trainee that this was called a fibrous mesothelioma because it was thought that it just occurred in the chest and abdomen, or chest and mediastinum. But since then, the number of places where it can occur has just continued to multiply: head and neck, and scrotum, and vulva, and peripheral sites, salivary glands, all these places, and so forth. Now, these tumors can be difficult to stratify for risk, but it's generally thought that the age, size, mitotic rate, and presence of necrosis kind of give us our best chance to stage this. So here's an example, and I think this is, I don't remember where this one is from, but there's a variety of morphologies that we can see with this tumor. So this illustrates one of the morphologies, which is what was once called a hemangiopericytoma pattern, where you have dilated staghorn vessels and this very thin endothelium and peripheral spindle-shaped cells with varying degrees of a mild to moderate atypia, and usually not very much in the way of mitotic activity. But as you can see, very vascular, sometimes very widely dilated vessels in this particular pattern. Because there's so many different patterns, I've pulled in a number of cases to look at, and this is one which is quite different, but as you see, shows this variability, nodularity, and so forth. Some people say that the kind of dense, ropey collagen is helpful. This case doesn't particularly have that, and in fact, it sort of looks almost a little bit epithelioid. And it has this sort of myxoid or edematous tissue in between these cells, which show a little bit more atypia than you might have thought of otherwise. So I think in any sort of spindle or epithelioid neoplasm that you're not clear what it is, adding a STAT6 to the immunoperoxidase profile will be very helpful to you. So what else is useful? Well, I mean, this tumor will be CD34 positive, it's BCL2 positive, and so forth. And that's helpful, but those are not specific because we see those in a number of other tumors as well. However, if that's all you have, then you may need to use those. Okay, well, moving on a little bit, this is a tumor that I think is very interesting because, again, this is something that can occur in a very wide range of sites. Originally, this was called inflammatory pseudotumor, but it's been recognized now that this tumor has oftentimes has an ALK gene rearrangement and some clonality and can recur or become aggressive. Typically, it's formed of myofibroblasts with some admixed component of lymphocytes and plasma cells in here as well. The most typical site is in the respiratory tract in children and young adults, but it really can be found in a wide array of other sites, the mesentery, the thyroid, maybe the gallbladder or other intra-abdominal sites. And so it again is something that you should think about. It's been seen in the gynecologic tract, for example. I haven't seen a case there, but I keep looking. And so this is, again, a tumor that has a wide array of morphologies. So here's a sample of some biopsies from a tumor like this. And as you can see, it's kind of a low-grade looking spindle-shaped tumor. Not much in the way of collagen here, but sort of this amphiphilic, pale purple-pink cytoplasm that we often associate with myofibroblasts. And so these tumors will oftentimes be SMA positive, but not desmoid positive. But that's helpful, but not, again, not specific, whereas the ALK mutation can really be much more specific if it's present. If it's not present, you may still have that the disease, but it may have a slightly different molecular signature. So you can see a few atypical cells here, and the nuclei are a little bit larger and so forth. So I pulled up a few other cases from another teaching set that I have access to. And I think this will show you on a biopsy sample how you might approach this. So you can see there's a degree of atypia here, some macronucleoli, and then all of these, smaller inflammatory-like cells here in this process. There's a desmoid stain here on this sample, which you can see here. Shows just a little bit of positivity. I guess that's a little bit is acceptable, not every cell. And here is the smooth muscle actin, which shows much stronger positivity in virtually all the cells, as you can see here. So there's the myofibroblastic component. And then this very nicely has an ALK stain to go with it, which shows you, again, the nice positive protein marker within the cytoplasm. This is not a nuclear stain, it's a proteomic stain, which shows nice positivity. But the presence of this is quite strongly predictive of the ALK rearrangement. Okay, let's go back here to our previous sample here. Oh, actually, I may have had one more here. Here's another example. This one, I think, from the lung. So yes, you can see here, nice pulmonary parenchyma. And here is this lesion. And you can see here, there's a lot of inflammatory component here, a lot of these inflammatory plasmacytic cells. And then here are your myofibroblastic streaming cells in the seemingly in between areas here. And again, just a very mild degree of atypia. Not a whole lot of mitotic activity. And in the lung, of course, you're going to entrap, histiocytes, alveolar cells, and so forth. So your staining can be a little bit different. And then one more example, this one, I think, from the mesentery, showing a little bit different morphology. Here is the low power view, and you can see we've got these little clusters of lymphoid inflammation here, and then intervening areas, some plasma cells, and the myofibroblasts may just almost kind of fade into the background sometimes. So here's a few, here's a few, here's a few, but it may look like this is more inflammatory, and so hence the term inflammatory pseudotumor. But you will find some areas where you have a little bit more of the myofibroblastic component, as you see here. Okay, so that's the kind of the spectrum on inflammatory myofibroblastic tumors, and some nice examples to illustrate our findings. We'll go on one more case here. Again, this is another case, more cellular than the previous examples, not as much inflammation. And you can see some extravasated red cells, relatively sparse inflammation here. But again, sort of these bland, low-grade spindle cells, a background of a few small vessels, inflammation, and so forth. So, part of the challenge in being a pathologist is recognizing the spectrum of disease that can be present. And so that's part of my hope here, is that you'll see some of the various patterns and sites of presentation, so that you'll think of the diagnosis in more settings and not be, how would I say, focused exclusively on just the one or two photographs from a textbook that you might have access to. All right. Well, this tumor can also occur in the skin. And here's a little example of that. Here with this little collarette around it, it almost looks like a skin primary tumor, but when we come into here, it's very much kind of like the same process, a mixture of inflammatory cells and fairly bland spindle-shaped cells, as you can see here. So we might mistake this for a capillary hemangioma that's become sclerosed or something of that sort. But in fact, this did have an ALK mutation. Okay, well, something you've all seen, I'm sure, is the GI stromal tumor, which for the most part is exclusive to the GI tract and most commonly in the stomach. But there are occasions when you can see it in other locations, out in the mesentery. I've seen it occasionally in the bladder, maybe in the GYN tract, but generally it's restricted to the GI tract. And this tends to be slightly older adults, 40 to 60 and so forth. And of course, the prognosis, if you look at the CAP checklist, there's a nice risk stratification table in that tumor checklist that helps you to evaluate the risk stratification for the patient, high risk, low risk, intermediate, et cetera, for recurrence and spread. That varies according to site, the size of the tumor, mitotic, and other histologic features that you may have. Now, we all know that this is most frequently associated with a c-KIT mutation, but there are a couple of other mutations that can occur. The platelet-derived growth factor alpha, and occasionally succinate dehydrogenase can also give you a GI stromal tumor. And oftentimes these other mutants will be much less responsive to the traditional therapy with imatinib or sulindapril. So this tumor, not a real challenging diagnosis. We see here mucosal surface. The tumor arises within the wall. It's located not within the adventitia, not within the submucosa, although occasionally it will extend upwards into the submucosa. And so you occasionally can see it on an endoscopic biopsy. But usually what our clinicians have to do if they sense there's a mass lesion is that they have to do an endoscopic needle biopsy, or the patient comes to resection. Now, as you know, this tumor has both spindle cell predominant and more epithelioid cell variants. This is a little bit more epithelioid, not purely spindle-shaped cells, and that's important to note. But again, it's fairly bland looking. It doesn't have high-grade nuclear anaplasia. It has, some small vessels. So you see there's really a common theme with these cases that have a lot of potential to be confused with one another if you're not aware of the issue that we're dealing with, or the location, or the patient age, and so forth. So diagnosis, I'm sure you're all very familiar with that. CD117, DOG1, those are the stains that jump out at us as being very conclusive. And I haven't put very many examples in here today because I know you've all seen these and you'll see them throughout your career. Now, another tumor that can have this histology is low-grade fibromyxoid sarcoma. And this is a tumor that is usually slightly younger than GIST and very different location. It tends to be on the trunk or proximal extremities. and only very rarely would it occur internally. So you're usually thinking totally different differential diagnosis based on the location and to some degree on the age. This was originally called the Evans tumor because Henry Evans at the MD Anderson is the one who described it and detected it as a slowly growing mass lesion in these young to early middle-age adults. As we have studied it more, we've come to recognize that like many other low-grade tumors, and as we've noted here in this little discussion, many of these low-grade lesions have a fusion gene that is responsible for the development of them. So if you see a low-grade tumor of this sort, usually it's not a very complex karyotype, multiple high-grade mutations. It's usually one driver mutation, a fusion or something, or rearrangement sort of thing that is responsible for the tumor. Now, the classic description of this tumor is that of nodular growth with alternating cellular and myxoid areas and sort of curved or curvilinear blood vessels. Now, you're not always going to see all of those necessarily, so you do have to keep in mind this possibility and the clinical presentation. If you have MUC4 as a stain, this can be helpful. Some places, the EMA, epithelial membrane antigen, also will mark this particular marker, so that sometimes serves a dual purpose. So here's a needle biopsy example. And as you can see, it's like our other needle biopsies. It's kind of low to intermediate cellularity. Not very cellular here, a little bit more cellular here, very low grade appearing spindle shaped cells, somewhat stellate. So, you know, this could be a fibromatosis, it could be any of a number of other things that we've just looked at if you're not aware of the clinical situation and so forth. Now, one difference here is that, you know, somewhat you might say these cells are a little bit more, you know, triangular or a little bit more stellate than some of the other lesions we've looked at. But I think in an individual case, it can be very difficult to distinguish these on a biopsy. And so, you know, including a MUC4, including a STAT6, including CD34, including the beta-catenin marker in your panel of these low-grade spindle cell tumors can be very helpful to begin to uncover what they are. Now, I looked and looked to see if I could find some curvilinear blood vessels, and this is about as close as I came to it here on this biopsy. So it's that vasculature finding is maybe not always going to be there in a biopsy. Well, let's look at a couple of resection specimens, and I apologize for the scanning lines here. This is a borrowed slide. So here we can see the sort of vaguely nodular pattern. Here it's a little bit more sort of onion skin-like pattern, and you can see some of the nodularity. Here you see some of the more you know, loose myxoid changes. And I think maybe you can begin to get a sense for a little bit of the curvilinear vasculature in this lesion. So again, higher cellular, lower cellular, and there's not a lot of myxoid tissue here. It's not overwhelmingly myxoid. Here's maybe a little bit more myxoid area here. Now, just as a matter of clarification, there's another tumor which, unfortunately, in English, has the same roots as those that are used in this tumor. So the term for this tumor is low-grade fibromyxoid sarcoma. There's also a myxofibrosarcoma. However, that is a very different tumor. It's a high-grade sarcoma. It's not a low-grade lesion like this. And so you don't even have to have them in the same differential at all. So low-grade fibromyxoid sarcoma, that's a very low-grade tumor. You may have a hard time discerning that it's a sarcoma on a biopsy. Fibromyxoid sarcoma, that's a very high-grade sarcoma. Previously was in the basket of undifferentiated pleomorphic sarcomas. So it's very high-grade looking lesion. So although the names sound similar, they're really miles apart in terms of morphology and prognosis. So here's another example of a low-grade fibromyxoid sarcoma. This one, you see much more myxoid tissue here. And again, this vaguely nodular pattern of tissue. Low-grade low-grade spindle-shaped cells. A little bit more maybe stellate or trapezoidal appearance. They're not quite as narrow and dense as fibromatosis, or even perhaps as solitary fibrous tumor. But there can be a lot of variability there. Now let's look at the vessels in this lesion and see if you can determine that there's any sort of curvilinear nature to them. Well, here's a few vessels, and maybe they're arching and so forth. They're very small vessels, very delicate, oftentimes very hard to discern. So I don't find the vasculature particularly helpful, except that I would, if I saw big vessels in this, I would maybe not think about this lesion. So if you have big gaping vessels, then I might go more towards, solitary fibrous tumor or angiomyxoma or something else. Now, what are these areas here? Okay, well, here's a couple of dilated vessels, but it may actually be more likely that this is an area of necrosis that is beginning to encroach on the lesion. Yeah, sort of necrotic type of an appearance here. Okay, well, sort of moving superficially, we can touch on Dermatofibrosarcoma protuberans, which also is a low-grade spindle cell tumor. But this, of course, most of the time is presenting in the subcutis, in the superficial sites. And again, it has a pretty wide age range. And as you'd probably guessed, we have a fusion gene. This low-grade tumor typically has a COL1A1 and PDGFB, platelet-derived growth factor beta, in most of these. However, this is not a totally unique fusion to this tumor. So the question is to whether or not the other lesions with this fusion gene are in some way related. Now, in contrast to solitary fibrous tumor, this tumor will be STAT6 negative, but CD34 positive. And that's a very helpful immunophenotype. Of course, the clinical appearance also can help you a great deal. So classically, when we think about this lesion, it's a deep dermis, and it grows out into the fat and sort of honeycombs around fat cells and engulfs them, leading them to sort of atrophy or shrink away as you see them happening here. And the cells, again, are kind of low-grade, monotonous appearing. There's a bit of a storiform or swirling pattern as we saw in solitary fibrous tumor in some of these this tumor. There's a phrase in English that was often used for solitary fibrous tumor, and I think it applies here of a so-called patternless pattern, the pattern without a pattern. It sort of looks like something's going on, it's trying to do something, but you're not totally clear what it is. And as you can see here, the margins with the dermis are infiltrative in this lesion. And the same is true into the subcutaneous fat. And here you see it extending down towards skeletal muscle here and the deep fascia. So this is clearly a deeply invasive tumor, and margins can be very tricky to establish with this surgically. I would say this pattern of engulfing the fat in this manner is really seen primarily in two lesions, Dermatofibrosarcoma protuberans and the fibrous histiocytoma or dermatofibroma tumor that can occasionally extend into fat in this way. If this is very extensive, I would not call a lesion a dermatofibroma, even though they may have somewhat similar immunophenotypes. But this pattern of invasive growth into the fat should signal malignancy. And of course, this is a low-grade malignancy, usually only locally recurrence. Metastases are rare, but it's still potentially aggressive locally. Here's another example. And here you can see this might be an even more difficult one to categorize because we don't have that basal growth. We don't have the depth of the lesion. This is just a punch biopsy. And the other thing we see here is something that you might be concerned about is we have a lot of pigmentation here. So there can be some pigmentation that occurs in some of these lesions, either due to hemosiderin or occasionally due to aberrant melanosomes in this lesion, although those are decidedly uncommon. And here there is a bit of sparing of the superficial dermis, the so-called Gren zone, but it's very hard to discern, where the tumor starts and where it stops here as we go superficially. All right, so here we go. The next case, nodular fasciitis. So this is an interesting disorder. Again, we have a fusion gene that is involved with this process. This time involving USP6. Again, this is not a unique fusion product because it can also be found in things like aneurysmal bone cyst and potentially some other lesions. But this is usually superficial, maybe on the superficial fascia. Occasionally, however, we do see it in deep locations. And in fact, our colleagues from Da Nang showed us a case of this at a deep location just this past week. Usually the patients are young adults, but tend to be rather wide age range. Early on, it was thought that this was a lesion that was related to trauma, but that has not been proven to be the case. May occasionally have a coincidental traumatic event, but not caused by traumatic injury. So here's an example that we can look at. And here we see a little bit of this sort of growth around fat, but very nodular appearance and a little bit of streaming to it. It's thought that this tumor can look a lot like tissue culture. And so many of these myofibroblastic-like cells will be very monotonous. Again, many of them will be myofibroblasts that have some actin positivity in them. There may be some inflammatory cells associated with this to varying degrees. And one of the reasons we have different morphologies with this, variable amounts of inflammation and so forth, is that this is a lesion that has a sort of a time course. Over time, it will appear somewhat different as it matures or as it becomes more uniform. And so it's expected that a lesion that's been present longer may be more uniform like this, whereas, as we'll see in a minute, some of the more, how would we say, recent onset lesions might have less of a dense cellularity like this. Now, usually it will be fairly rounded and circumscribed, but fortunately, resection margins are not critical in this lesion because the recurrence risk after surgical excision is very, very, very low. So here's another example, again, one that we see kind of in the deep fascia right next to the skeletal muscle here. And this is one where, again, we have variable amounts of spindle-shaped cells, but here maybe a little bit more inflammatory cells and so forth. Now, these lesions are often very mitotically active, and so it's frequent to find mitotic figures in these lesions. There's one. Probably we'll find others. Here's maybe another one there. And so those are always typical mitoses. There are never atypical mitoses in these lesions. And that should be a helpful feature, but certainly finding a high mitotic rate can be worrisome for some people. Notice also the extravasated red cells. The vasculature in these lesions is not well developed. It's not mature. And so you tend to get a lot of this sort of interstitial flow of blood in between the spindle-shaped myofibroblastic cells, more like granulation tissue at times. So maybe right here it's trying to form a blood vessel or something of that sort. Now I'll post the link to these digital slides afterwards so that you can study them at your leisure, or if you have a case so that you can come back to them and say compare with the findings that we have in these reference cases. Because I think it's always helpful to have, if you have a case, to be able to look at what other things look like. I had a colleague when I was much younger who would annotate his textbook, and he would, if he had a text of DermPath or whatever, he would oftentimes write case numbers of different entities in the sidebars of the pages that he was looking up, so that he would have a slide that he could go to. And that's because, fixed pictures in an atlas or something, they're useful and so forth. They give us an idea, but many times it's the process of interacting with the slide in a more full context that helps us. So in this case, in this biopsy here, you see a very inflammatory process. Lots of eosinophils and red cells here. Lots of extravasated red cells, and not very much in the way of the fibroblast. It's kind of out of focus there. Sorry about that. Here we're probably, well, let's see, are we in the breast? Yes, it looks like we're here in the breast. There's some nice breast tissue. And so this is a lesion within the breast tissue. And you can see that it's got a few of these sort of myofibroblast type cells, a lot of eosinophilic cells associated with this, as well as the other inflammatory cells. So why is this not something, why is this not just an abscess or a reparative wall of a granuloma or something like that? Well, that's where the UPS 6 rearrangement comes into play and helps you to define that, or USP 6, excuse me. Now, unfortunately, there's not an easy immunohistochemical stain, and so you may have to go on other features, lack of other features, and so forth to make your diagnosis. Okay, well, while we're in the breast, we should talk about another lesion that we touched on, I think, a previous session or two about when we were talking about spindle cell tumors in the breast. But myofibroblastoma of mammary type can occur in the breast as well as in the vulva. And this, again, is a fibroblastic, myofibroblastic tumor that has lost RB expression. And it can have various appearances, but one of those is kind of a spindle cell pattern. This is not a very mitotically active lesion, and usually would be distinguishable from others. But I include it here just for kind of completeness sake, I guess. And here is a nice example. In this lesion, notice again, we're sort of encompassing fatty tissue. And the morphology is very collagenous, very low-grade spindle cell appearance in this situation. So, it fits into this category of low-grade spindle and collagenous tumors that we've been talking about. And gives you another entity to consider depending on the location, the age, and the clinical circumstances. So there you see how collagenous it can be, and these fibroblasts here can be very, very bland. Here's another example, this one a little bit more cellular and robust, a little bit more collagenous, and you can see how this might be confused with a solitary fibrous tumor or some other low-grade spindle cell lesion. Again, very delicate vasculature, entrapped fat, location in the breast or in the mammary milk line sort of thing should give you a thought to think about this lesion. Here you see the benign breast tissue adjacent to it, and so forth. So variable size, this pretty small lesion. And another example, here one that sort of encompasses breast parenchyma or infiltrates around it. And again, a very kind of ropey collagen appearance. So this lesion, I think as we indicated, can look a lot like solitary fibrous tumor, but it would be STAT6 negative, and you would have lost the RB marker. Let me just go back here to our, just remind myself about the immunohistochemistry here, because I think this tumor can have positivity, yes, for CD34 and BCL2. So it can look a lot like the solitary fibrous tumor. But the difference would be no STAT6, and if you have access to a stain for RB, no expression of RB marker. Okay, well, we're just about done. I have one sort of final lesion to share with you. Oh, well, here's another example of the myofibroblastoma. Again, kind of very bland spindle cells, collagen, a little bit of myxoid change here. You can have associated fat within the tumor, more cellular areas here. Doesn't this look a lot like that solitary fibrous tumor we looked at earlier? Almost has a hemangiopericytoma-like pattern. Okay, so let's take a look here at the sclerosing collagenoma. So this is a lesion that typically occurs in the skin. However, we have recently seen a case in an intra-abdominal location, so I don't think the skin is exclusive, but certainly very most frequent. And in terms of where on the skin, just about anywhere. This also has an association with Cowden's disease and maybe has an associated P10 deficiency, which is important to detect if you can, because these patients are also at risk for other tumors. So I have just the one example, this one from the skin. And as you can see, it's generally rounded, circumscribed lesion. And one of the distinctive features about this is this kind of very patterned appearance of the collagen. It tends to be almost keloid-like or scar-like collagen, and it tends to have this sort of rounded or lamellar pattern in areas, as you can see here, little cracks between the collagen fibers. And that's very characteristic of this lesion and can be a very helpful diagnostic clue. Now, another thing that you may see is that sometimes you'll get multinucleate cells, and occasionally in the core of these lesions, these little vessels may occasionally calcify and leave you with a Samoma body type of lesion in the core of this. I have some special stains to go with this, and the trichrome stain, I think, is a particularly attractive stain because it really just gives you this almost, how would I say it, modern art kind of appearance of the spacing between the collagen. And it can be really kind of an exciting appearance. This might be the kind of photograph you'd blow up and put in an art gallery or something, maybe, because it's just so stunning a pattern that's being created with this. So here is the CD34 stain, which can show a little bit of positivity in these fibroblasts and cells, as well as in the vessels. And then we did a P10 stain, which it looks a lot like this is positive, but if you come in here and look, this is supposed to be a nuclear stain, and all of the nuclei that you see in here, other than the vessels, are negative. So the vessels can be positive, but your collagenous producing fibroblasts here should all be negative in the situation where you have P10 loss. And so this is a nice reference example of what the P10 would look like. Now, just for illustration's sake, you see here that they've used a multi-purpose control tissue, which consists of multiple small fragments of a variety of tissue types that they put onto their control slides. And because P10 is such a frequently and critically retained marker, virtually everything is going to stain with it. And here you see the positive cells here in many of the positive control tissues here as well. So, so that's a sclerosing collagenoma or a collagenous fibroma, but either of those terms are acceptable, I believe. Okay, so we finished with some time for questions, and I know I've talked about a lot here, so I'll just open it for questions for anybody who'd like to speak up.
Thank you so much, Professor, for your excellent talks.
Well, I hope it's helpful
Yes.
when you encounter these tumors the next time.
I have some question to you.
Good.
Yes, talking about soft tissue, formerly I hate it because it's very complicated. But when we learn step by step, I like it. Yes, right now I like it and I try to investigate, but I still do not understand well some terminology that they use in this tumor group. Sometimes it looks complicated and not relevant to the meaning. For example, the word of atypical fibrosarcoma, atypical histiocytoma. Sometimes I understand this is not malignant because the word oma, not sarcoma.
Yeah.
But when I look many articles or in the book, this means that not benign. Is it true?
So that's a good question. Atypical fibrosarcoma, I think in most cases is benign, but they're beginning to sort of separate off pieces or portions from that tumor sometimes that have more aggressive behavior. And then they don't always have a good term. And in pathology, you know, our words are really confusing sometimes. I was teaching the students this week, and in one section of my lecture, I talked about, you know, dysplasia in colon polyps, and then I started talking about angiodysplasia in essentially vascular malformations, which is the same term, but you know, very different meanings. And so your frustration is a very common one in English. So you just have to sort of see and be patient to let those things begin to sink in as you study more examples and share and see what other people want to call them.
So in this case, atypical fibrosarcoma, atypical histiocytoma is not benign, it's malignant. Why do they not use the word sarcoma instead of atypical?
I think the reason they haven't changed that terminology is because is kind of what they say, it's ingrained in the literature. It's it's got a very long history of articles on that topic. And so if they make a new name, it's hard to link into that literature history. So they keep the same name, but then they try to educate in terms of the biology. Yeah.
Okay.
And
so
I'm not an expert on that terminology stuff, but I do share your frustration.
Yeah.
Now they have sometimes, you know, they're willing to do this as they take a large group. So say like the you know, what used to be called malignant fibrous histiocytoma, they have been fine with dividing that up now into, you know, myofibroblastoma and other types of now more differentiated high-grade sarcomas or distinguishable high-grade sarcomas that they can begin to separate out as we learn more. And that will probably happen with the fibrosarcoma terms, the atypical fibrosarcoma terminology. But in general, that's a tumor that has a relatively low grade or low risk of metastasis kind of lesion, but does have some risk associated with it.
And they are in the group of pleomorphic sarcoma, right?
I guess I would say yes, because it is it's not a specific history.
Morphologically, it's difficult sometimes to differentiate from pleomorphic sarcoma among these atypical fibrosarcoma or atypical histiocytoma. Sometimes very difficult.
Yeah. I agree.
And I want one question. You just talked about the moment about the fibromyxoid myofibroblastoma mammary type. Why we put this term mammary type even we see in the other places?
The breast is the most frequent location, and it seems to be common in that location as well as in milk line locations. I think there are some other myofibroblastic tumors that would be distinguished or would be in other areas or other categories. And so they may or may not. I don't think they have the RB1 loss factor, but I don't know why they call it mammary type, other than that's the most frequent location and where they've characterized it.
So it seems that there should be held the non-mammary type of myofibroblastoma.
I think there are some tumors that they would classify as myofibroblastic that are not this mammary type of tumor. Yeah.
Okay. Okay.
Yeah.
Yes, I will learn. I will try to see. Thank you so much, Professor. Thank you.
Okay, well, it's good to see you, and we will talk again.
Dr.
Yes.
Hassel,
Yes, Dr. Mary.
I also have one question. Can I?
Yes, please.
Yeah. So I have the same a bit like no, I had a question about myoblastoma of the breast, and how can we differentiate, in the core biopsy between I mean that how can you go with the core biopsy between myoblastoma of the breast and some like carcinoma with spindle cell, with the core biopsy when we have only at the periphery of the core and we see some like maybe a carcinoma, we are not sure. And can we start, how can you go like, you start with the marker with beta-catenin or other marker to differentiate between low grade spindle cell, or you go directly to a carcinoma first, or what can you do with this case?
So I think the first step is, the histology. Your H&E stain has a lot of information in it. And so, spindle cell carcinomas usually have a higher degree of atypia in terms of cytology. So you should see more cytologic atypia and variability in the cell nuclei and so forth. Whereas myofibroblastoma, there's very low-grade nuclei and so forth. Nodular fasciitis, it could also be in that differential, a little bit, but that would usually have, again, not much atypia and, sort of an inflammatory background. And then I would go to a limited panel, pancytokeratin, CD34, maybe an actin, those sorts of things that might give me a clue that I was dealing with a more stromal tumor versus a epithelial tumor. And most spindle cell carcinomas should stain with a pancytokeratin.
So, for example, now I have a case that I have CK7 positive, AE13 positive, and when we like try with estrogen receptor, and there are some positive cell, and I think it's odd. I don't see much atypia, and
well, but your immunohistochemistry panel is helping you to decide that it's carcinoma, because myofibroblastoma, solitary fibrous tumor, nodular fasciitis, those are not going to be keratin positive. So that is the value of a good cytokeratin stain, and you've done the right thing by having more than one. I like to always say 2 negatives and 2 positives to really feel confident with any diagnosis.
Yeah, it's sometimes a bit challenging why we try to limit the number of IXC stent.
Yeah, the cost, of course, is a concern.
For that, yeah, thank you.
Okay, any other questions? Well, thank you so much for being with me, and we will look forward to our get together next time. Please feel
Thank
free
you so much.
to send me any of your questions or anything I can help with. Have a good day.